This is Professor Michael Chapman. I'm one of the most experienced IVF doctors in Australia. I believe that an important part that I can contribute is to educate patients in relation to fertility, infertility, and all that involves. These series of podcasts help to educate you. I hope they are helpful to you. If you wish to know more, however, I'm more than happy to have you contact me via email, which is profmchapman@gmail.com, or make an appointment to see me on 9138 4222.
If someone has fertility treatment elsewhere, do they need to obtain their records?
I often get second referrals from patients that have tried elsewhere and haven't got pregnant. And it is very useful for me to see the detail of what was done before so that I can plan for what we're going to do going forward to see if I can improve on the outcome for the patient. Yes, it is very useful for the new specialist to have as much of the old records as possible. Clinics have an obligation, because those notes are actually your notes, to give you a copy of your notes. Some charge a fee for that, for the administration. Sometimes there can be a delay in doing it because it's obviously not their top priority because you're a patient leaving them. Talk to the admin manager in that particular clinic. That's the best person to talk to in terms of getting hold of your old records.
Prof, we have a question from Famata. If you have any eggs left, is there still hope through IVF? Maybe the question means if you don't have any eggs left, but the words read, if you have any egg left, is there still a hope through IVF?
Obviously, once a woman goes through the menopause, so periods have stopped and she's had hot flushes, then really IVF is going to be no help in terms of her eggs. That doesn't mean that even after the menopause, we can't use an egg from another woman to create a pregnancy that you can carry. So IVF can still play a role even in that patient. More commonly, the patients I see particularly in their early to mid 40s, where the ovarian reserve, the number of eggs, has really dropped to almost nothing. They're still producing one egg a month and therefore have regular periods. And the odds of success with IVF in that scenario of very few eggs is very low and almost the same as trying on your own. But I certainly, my experience has been that women in that scenario of very few eggs, will, even if I tell them the chance of success is 1%, they will still go forward and have treatment to give that one chance, and they could be the 1 in 100.
How will I be watched during ovulation induction?
No.
Are ultrasound and blood tests used?
Yeah. Ovulation induction is where we're trying to make you ovulate when you haven't been ovulating before. The most likely diagnosis in that situation is going to be polycystic ovarian syndrome, where ovulation is intermittent and cycles are irregular. That's the commonest reason for doing ovulation induction. Doctors vary in their views about how much monitoring is needed. So the reason for monitoring twofold. One is to help time ovulation so that you know when to have intercourse. That's one rationale for monitoring. And obviously, second reason is to make sure you are ovulating, that the medicines are working. The third reason is to avoid overstimulation. Now, that last one is incredibly rare with the tablet medications that are used for ovulation induction, like clomiphene or letrozole, Femara. The incidence of ovarian hyperstimulation is something in the order of 1 in 1,000 cases. In fact, I've never seen hyperstimulation with tablets. In terms of proving that someone has ovulated with the tablets, a simple blood test on day 21 after the tablets have started will give us that answer. We measure progesterone levels, and that's all we do. And I have to say that's the only monitoring I do for clomiphene or Femara, is to check for ovulation. Ovulation kits will tell you when ovulation is occurring, and therefore that's all I think is necessary. But some doctors, looking like they're caring more, will do blood tests every second or third day, do ultrasounds to show you the follicle. It just adds expense and really, in terms of outcome, makes no difference to the pregnancy rates. So personally, I'm a low monitor, but there are doctors who do monitor much more closely. And for some patients, that's helpful for them to know when to have intercourse, and they feel they're being looked after more.
And don't forget that you can access all the previous episodes by going to our website www.theivfjourney.com and select IVF Journey podcast from the navigation menu.